Deciphering the role of prostate MRI. Is that what?
Yeah,
Yeah.
that's what's there.
Well, can you introduce?
Sure. Hi, it's my pleasure to be here. Thank you, Ingrid, for inviting us. I'm here on behalf of the Focal Therapy Society, representing our organization. I will put a QR code up at the end if you guys want to get involved in a committee or you're interested. We'd love to have you, and it's a special time for us because I believe focal therapy is the next area of exciting study in urology. Today, I'll be going over deciphering the role of prostate MRI for risk stratification of prostate cancer. And I'm currently at Northwell Health. I'm a urologic oncologist as well as an interventional radiologist. Could I have my timer up for 20 minutes, please, so I can keep track of myself? These are my disclosures, or 15 minutes. Current urology practice, state of the art. I love this slide. They're watching grayscale ultrasound on the TV, and that still happens a lot today. But as of January of this year in the US, they've really prioritized image-guided biopsy because the performance limitations of the prior standard biopsy that we've been using for the last 40 years, we found that it really doesn't perform well, and I'll show some evidence of that today. The three topics I'll cover is the role of the MRI for prostate cancer diagnosis, targeted biopsy, and from imaging to treatment. The last talk was awesome, looking at the impact of PSMA PET CT. I think that's playing a significant role. As a caveat to that, we have to understand that in the US, we just changed our coding for prostatectomy and lymph nodes, and it's kind of been rolled in to de-emphasize the financial benefit of doing a pelvic lymph node dissection. And I think that'll have a big impact on the number of people actually doing that in the US. The journey of the prostate biopsy, digital to digital. I love this slide. How many people here have done a digital biopsy? So when I was a resident, I at least had the opportunity that we only had one ultrasound in the department. And if it broke, I always quizzed the residents, what's that straw for that's on the end of the biopsy needle and how to use that? They look at it, oh, it's just to protect the needle. I'm like, no. You cut off the first 2 inches of it, use that, 2 gloves in your finger, and just don't biopsy your finger. So we've gone digital to digital in the last 100 years. And I think where we are today, a lot of our advances happened in 2008, 2009 with the advent of imaging. You can see inside the prostate as well as targeting. That's my last slide over here. This is the original prototype fusion biopsy machine developed at the NIH with Peter Pinto, Brad Wood, Peter Choike, and myself on that original team. Speaking of my team members, they're down in the lower right-hand corner. To give you the perspective is our first publication, 2007. There was some work done very early on, but this device and this technology never took off and kind of died on the vine. It could have died for different reasons, but the first FDA-cleared fusion biopsy device was 2007, 2008. It was a surgical device for navigation, and then the first commercial product you can see here did not, the first commercial approval is Euronav right here. And then it wasn't released till 2013 into the general public. And since then, it's been only 13 years to make it to the guidelines. So I think it's moving quickly, minus my sarcasm. And Dr. Wood got in trouble at the AUA for our first course. He said a biopsy without imaging is malpractice. And the AUA made him stand up and retract the statement. And I think he was dead on then, and he's still dead on now. And unfortunately, there was a significant amount of pushback from the ultrasound biopsy group and the ultrasound people that that was not appropriate to say that. Ultrasound is imaging, and even though it does not perform well in predicting prostate cancer. And you can see the growth in the publications, it's exponential. What PSA threshold do I order an MRI at? I think this is important. I think this has really lost a lot, especially in the US, because we have CLIA certified labs that turn a PSA of 4 red. At our institution, we have a disclaimer on the bottom now that says the American College of Surgeons, NCCN, say at 3 is abnormal. But really, when you look at the data, these are the thresholds. These are from the publications, the Godeberg study, looking at that. It's a great screening study. Looking at a highly enriched population, the optimal cut point was 1.8. And then for your 50s, 2.5, that's really what I use in my practice. And any above 3 really take into account the risk stratification, decide. All the guidelines include MRI and risk stratification, how you do it. No one goes from PSA to biopsy anymore. But as you know, this is a young picture of Dr. Pinto. I always like to show off. Dr. Pinto is one of the leaders in the field. If you don't know him, he's a great guy. But do you guys really know what happens at the NIH when he gets up from his chair and walks down the hallway after he's been one of the leaders in the field? I have a secret video for you today. So this is what it's like to be Peter Pinto at the NIH, help a little AI. But that was the beginning. We took a lot of heat for these ideas, but I think it's really taken hold and changed the field as we know it. This is the study that I was alluding to about what the optimal cut points are. And I think it's just important to understand that 4 No More was a campaign that was launched and fell flat early on when people tried to change and re-educate people, because 4 was the cut point that was created and approved by the FDA in 1994. The next question about MRI is, when do I order a repeat MRI? And this is from the same cohort from the Gothenburg study. It seems to be safe, a 2-year interval for men with a negative MRI. But what's a negative MRI? I think it's really important that you check your own films. And PIREDs 4s and 5s with a negative MRI should have closer follow-up. I typically get a repeat MRI at 1 year. We did a study at the NIH. Low-risk lesions take at least 3 years to change any image characteristics. And we understand that, you'll see later, the phenotypic expression has an underlying germline mutation or somatic mutation that can lead to these changes that we see in the visualization on the MRI. Biparametric or not? Great question. I am 100% for contrast right now. In the United States, in our practice, we do not have a capacity issue. People that move to bioparametric are mostly due to a capacity issue. And why is this really important for me to stop and take a moment to talk about this? Is because your radiologists most likely do not have the depth of experience to go to a biparametric. And all the data that we do see is that novice readers make mistakes, and contrast is our training wheel. Imagine 19% of the time you miss a lesion because you don't have contrast. So I think that's really important to understand. There is a cost with this, so you do have to try to decide what the cost-benefit ratio is, but it's something that you should take seriously. Biparametric MRI or multiparametric. It has 3 components: the anatomy, looking at the biology of the disease, and the vascularity of the lesion in the prostate. I put this up. Biparametric looks great. When you have a medical student reading your scan, if it's a 1 centimeter lesion, that's almost unmissable in today's resolution of the MRI. So when you set a threshold at 1 centimeter, and all the AI companies do this as well, they use a 1 centimeter diameter lesion. This is enormous on prostate MRI. And these are things that should never be missed. Our challenges are in the 5 millimeter, 7 millimeter area. And I think that's where they really fall off in performance. Again, the funnel changes, and our funnel is this. We have PSA-based screening, the prostate MRI, 27 to 54% could have a negative MRI, depends on your institution. You could have a biopsy at that point, or another urine biomarker as a decision tool. And then we use genomic classifiers to decrease or substratify patients to treat or not treat. Can we be comfortable with active surveillance? And then move on to actually treatment with clinically significant prostate cancer. This is how our funnel has changed. I think we're diagnosing smarter and treating better. I'm going to do 3 quick studies. I'm not going to spend a lot of time on this, but this study has really made it a challenge for us in the focal therapy world to claim that you need a 1 centimeter lesion margin for a lesion to do adequate focal therapy. This is absolutely incorrect. Absolutely the worst study that ever is done. I'm friends with all of these people in the study. What was the problem? A biomedical engineer used data for biopsy data sets to draw conclusions of how far the tumor was gone. So Margolis, which was there, Dan Margolis, he's the radiologist. He's like, I never designed the study to do that. I circled the most optimal area for biopsy, not the entire area. And I spoke with Lori Klotz. We're going to, this is just kind of gotten stuck in the dogma of focal therapy. So the better your imaging is, the more tailored care you can have. You still have non-imageable disease, and it's difficult at the margins, but it's certainly not 1 centimeter. Because the quality of the picture, look at this. Does that even look like a T2 weighted MRI? You can barely make out the shapes in the prostate. Another group, Tanasia's group. He's my new boss, by the way. I'm trying to be very supportive. But if you look at their scan, you can actually see the outline of the capsule. They looked at it, and they felt that they wanted a 9 millimeter treatment margin. but they also came to a different conclusion on the underestimation of tumor volume. But take a look at this picture, a little better than the last one, right? Now, here's the NIH group that I was with. Look at the difference, and this predated their scans. This was the first study, 2012. Look how nice the architecture is. You can see behind it. And we felt we were only underestimating by 7%. So your reality dictates your conclusions. And I think it's an important thing to understand, because when you get to the next slide, can I have a next slide, please? Gracias. So you look at this, and this is what their conclusions were. You can see NYU and the NIH are very similar, but that UCLA study was underestimated by 80%. So I think it's important to understand those differences. Next slide. This doesn't work. Lastly, this is the best MRI I've ever seen. If you see great MRI, now you can know the difference, and then your conclusions will be different based on the quality of imaging. Next slide. Don't become the prisoner in the cave in Plato's allegory. You do not know your lack of education and your impact on your conclusions. And I think it's really important to understand this. This happens in prostate MRI all the time. Everyone thinks they have great imaging until they see someone else's. And then their understanding of the entire process shifts. And then that also shifts how you treat patients and stratify them. So become the freed prisoner. Should systematic biopsies be replaced by targeted biopsies? I don't think so. I know Raju and I were talking this morning about a new study in AUA News, but 35% of clinically significant cancers are missed by MRI. But what's missing? That's the challenge. We understand there's some genomic markers and more aggressive forms that have a better or improved phenotypic expression that you can see it on the MRI. And you have to understand what your intention is. Is it for just diagnosis and screening, or are you using this information for treatment? In the area of focal therapy, imaging matters and it impacts your cancer outcomes. Does overgrading of target biopsy on MRI, image visible lesions of prostate lead to overtreatment? And the answer is no. There's some data here, but for the sake of time, I'm moving through it. There is upgrading, but most downgraded still had clinically significant prostate cancer, and you have 17% overgrading, but only really results in about 2% of overtreatment. Confirmatory biopsy is still necessary in the active surveillance population. And that's a great question. People feel they can defer the confirmatory biopsy and move that out to a longer duration, because there's less reclassifications. If you have 17% of upgrading already, you're having an enriched data set. So I think there's some validity here. We are trying to increase our duration. We still do a 0, 12-month, and then we push that to 3 to 5 years after that for biopsies with interval imaging based on that. Typically, the Europeans, Mark Emberton's group, a 20% change in their baseline PSA in the negative screen cohort, they'll reimage to reevaluate. So that's the threshold they use from their primary care colleagues, because they don't see the patient back after that. Cedric was talking at dinner last night, and we're talking about MRI and DRE and screening. I think the biggest problem is that our imaging shifts the patient upgrading because it goes from CT2 to T3A. But it hasn't made it into the NNA guidelines looking at staging. Why is that? Because it's not homogeneous around the planet. So we're still really grading people based on the DRE, which I think is still a part of this, especially prior to treatment. This was a study from Barris at the NIH. I mean, it makes sense. You have a big lesion at the apex, you have a higher chance of having a positive lesion or positive margin. And I think it's the challenges we have with surgery and where you dissect. And I'm going to talk about, understanding the anatomy and where the lesion is can have a big impact on this. And talking about, they also spoke to MRI detects seminal vesicle invasion with a 58% sensitivity, but the specificity is 96%. So you're able to rule out that type of disease. We don't typically biopsy the seminal vesicles anymore like we used to do for the radio recurrent prostate cancer. The challenge is how do you use the MRI? And they wanted to look at the clinical utility of the MRI in the decision-making process. How often does it change surgical plans? In this study, 35% of cases. And there you can see there's a somewhat equal distribution of the patients. But the two major ways was changing the aggressiveness of dissection indicated by EPE. We've been doing this NIH forever. There's a tumor on that side, go a little wider. Make sure you're careful. Don't let the fellow dissect that portion of the neurovascular bundle off the prostate or do the pedicle in that area. And that does impact it. But it also could improve and allow you to do nerve sparing when maybe you didn't in the past. So I think it helps personalize the surgical management of your patients. And another study looking at the impact of preoperative MRI on high-risk patients. So we talked about the wider excision of the patients, increased nerve sparing. So I think these are all positive things in this space. And I believe the MRI should be, if available, part of the pathway prior to treatment. Here's a great slide. So we did a study on the impact of positive margins and the cost in the US. And we do approximately 90,000 patients a year in the US for prostatectomy. And 25% will have a positive surgical margin. Now, I'm not going to get in the debate, is a positive margin really clinically significant? A lot of people downplay that. However, the data shows that of those 25%, 55% will have a biochemical recurrence, and 25% of that group will go on to have metastatic disease. And the total cost per year is about $1.1 billion over a 10-year care cycle management. It's a big number. Switching gears a little bit, looking the features of MRI visible and versus invisibility of cancers. And Emerton and the Europeans really are saying if you have high volume grade group 1 disease, that's not the same thing as grade group 1 disease doesn't have an MRI visible lesion associated. So there is some risk associated with having tumor volume, because just to have a 0.2 cc lesions, about 50 million cells. And it depends how you measure those cells, but that's a reasonable estimate, 30 to 50 million cells. Key points here, MRI upstaging and clinical to T3A. The key takeaway points, it detects EP earlier, and it has an impact on your surgical planning and radiotherapy decisions. I think, unfortunately, sometimes in radiation medicine, hormone therapy is added on and upgraded from radiation therapy. I'm going to skip this for this. It said 15 minutes, Ingrid. I thought I was 30, so I'm going to try to. Okay. Okay, because it said 15 there and it's 30 on the program, so I just want to make sure I'm okay, so I can slow down a little bit. How am I doing so far? You guys all with me still?
We have 30 on Friday.
Oh, I'll be done in a moment.
Do not worry.
I mentioned the radiation therapy escalation, which I think is a problem. Looking at AI and lesion detection is the grand challenge of prostate cancer and MRI lesions detection tool. There's different methodologies. A lot of this is machine learning on looking at pattern recognitions and radiomic features to detect prostate cancer. And they showed that AI did outperform the radiologists when looking at predicting prostate cancer at PI-RADS 3, 4, and 5. The problem is, again, is how big of a lesion is that? And they're using 0.5 or 1 centimeter lesions. In biparametric, it also improved the performance of detecting clinically significant prostate cancer. However, the challenge is in my view, when you compare it to the expert, it doesn't add very much. If you're really good at reading prostate MRIs, you can outperform this. Like I alluded to, a 1 centimeter lesion should be very difficult to miss, 0.5 cc's. Looking at different readers, again, it's always the experience has the impact. And I think AI's sweet spot right now is for the novice as training wheels to make sure nothing's missed when people are assessing risk for prostate cancer. Finally, if you look at it, MRI crushes the risk factors. MRI is if you look at the PCPT, the ERSPC risk calculators, MRI, if the area under the curve is 0.77 or 0.82, MRI makes up 0.65 of that. It outperforms all the other things with respect to Gleason score, PSA, and risk stratification. So MRI is our major tool we have today. And in closing, I want to say thank you for allowing me to speak. If you're interested, please scan the QR code, sign up with our Google form. You can reach out to us, participate. We're always looking for people from around the world. We have at least 46 countries of speakers that have come to our meetings, and we continue to grow and push the field forward. So I'd like to say thank you for your time today. I'll see you guys on Friday.